Yes, sir. So kindly allow me 2 minutes of yours. After a small introduction, I will be handing over the session to Snehal ma'am, right, ma'am? Right, sir?
Yes. Prashant sir.
Hello. Okay, let's start the session of today. Good afternoon and welcome to one and all. I'm Rituparna from Clarnet, the Resignation Session Assistant for a seamless experience, and Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clarnet is very proud to be a digital partner for this event organized by Prenatal Pathshala, Gujarat State Chapter. And the topic for today's session is lessons from experts, recent advances in RDS. So without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Prashant Karia, the Honorable Secretary of National United Forum, Gujarat. Over to you, sir.
Thank you, Rituparna. On behalf of NNF Gujarat, I, Dr. Prashant Karia, Secretary NNF Gujarat, welcome one and all to Neonatal Pathshala. Neonatal Pathshala, we are having this since last 1.5 years, and we are thankful that today we do have an expert, Dr. Pratima Anand, with us, who is going to take lesson from experts, recent advances in RDS, and the session will be moderated by Dr. Snehal Patel. I request our President, Dr. Dipen Patel, to introduce today's faculties. Thank you.
Thank you, Dr. Prashant Bhai. It is really a privilege to have with us Dr. Pratima Anand and Dr. Snehal Patel, who are as expert and moderator for this session. I know Dr. Pratima Anand since a NeoCube workshop she has organized at National Neonatology Forum level, and she has done a wonderful job and trained many nurses across these states. So welcome Dr. Pratima ma'am. I also welcome Dr. Snehal Patel. I would introduce Dr. Snehal Patel first, and I request Dr. Snehal Patel then she will introduce Dr. Pratima madam. So Dr. Snehal Patel has done DNB Pediatrics. She is a fellow in neonatology and perinatology. She is at present currently working as a consultant neonatal and pediatric intensivist at KD Hospital, Ahmedabad. She has her own interest in neonatal ventilation, point of care, neurodevelopmental follow-up of NICU graduates. She is also an instructor for various workshops like simulation workshop, basic NRP. She is also a state and national faculty in state and national conferences. She is currently the EB member of NNF Gujarat State Chapter for this current year. She is also a Joint Secretary for Gujarat Women's Week of the current year. She was the past EB member of Ahmedabad Women's Wing for last year. She has published in various national journals, and she was the editor of Gujarat NNF Bulletin Neobliss for the year 2019 and 2020. I request Dr. Snehal madam to introduce our expert, Dr. Pratima madam.
Thank you so much, Dipen sir and Prashant sir, for giving me this opportunity. What we are going to discuss today is an RDS. RDS is a very favorite topic of all the neonatologists, and what we see is there are so many advances over the period of years in the form of surfactant administration to insure techniques, then Lisa-Misa, and now NAVA. So we have an expert today, Dr. Pratima Anand ma'am. I'm honored to welcome you, ma'am, today. Dr. Pratima ma'am is the neonatologist from AIIMS, New Delhi. She is faculty at Lady Hardinge Medical College, New Delhi. She has more than 50 publications in various national and international journals. And her core areas of interest are neonatal intensive care, neonatal sepsis, neonatal research, and neonatal nutrition. She's a co-investigator in immediate KMC study, follow-up of immediate KMC studies, neonatal sepsis biology, and role of biomarkers in a neonatal sepsis. She's also an NNF Delhi State Coordinator for National Trainer for Advanced and Basic NRP. She's a National Trainer in Pediatric Advanced Life Support and Basic Life Support as well. And she's a National Trainer in Faculty-Based Newborn Care and National Neonatal Trainer for the preterm care packages. Welcome you, ma'am, on the board, and handing over the session to you.
Thank you so much. Yeah, at the outset, I think I would like to thank NNF Gujarat, Dr. Prashant, Dr. Dipen, Dr. Snehal for giving me the opportunity. And as Dr. Snehal said, I hope I am audible, and I'll be sharing my slides now. Yeah.
Yes,
Thank you. So as Dr. Snehal said, RDS is one of the most common illnesses a preterm neonate faces inside NICU. And with the evolving science, with fast evolving science, there have been many updates, many reviews, many literature editions in the past few years. And recently, we did have consensus statements along with guidelines, including NNF guidelines as well as European guidelines, which have compiled the most recent evidences and then given certain recommendations. I must say that these are recommendations and these are just guidelines, and they do have caveats. So let's go through all the recent recommendations which have come up in the last 1 or 2 years, to be specific, in the last 1 year. So today we'll be taking you through the RDS updates through the European Consensus Guidelines, the update of which has come up recently in 2022. Published in 2023 rather. Then we have National Neonatology Forum, our own clinical practice guidelines, which were again published released in 2022 and based on the most recent evidence. And these European guidelines have been updated every 2 to 3 yearly, and last update we had in 2019. And owing to the upcoming literature and certain recent advances, they have again updated in this year. Apart from that, last month only, we had another consensus-based statements by experts from US, which is the RDS Next workshop, which was conducted. And they also conducted a Delphi survey amongst 20 panelists and experts on respiratory management. And they have also given consensus statement on the surfactant therapy in preterm neonates with RDS. So we'll be going through all of these in a sort of brief, summarized way over the next 45 minutes or so. So we all are aware about the basic management of respiratory distress in preterm neonates. It begins with opening up the alveoli, giving surfactant because they are surfactant deficient, the preterm neonates, maintaining it with a good non-invasive respiratory support, which is now the cornerstone of therapy in NICUs. Moving on from the invasive ventilation, now we know that doing less is maybe better in newborns, and hence the non-invasive respiratory support in various forms. And then, of course, caffeine, which is also a popular drug for RDS as well as for apneas in preterm neonates. So these are the basic principles of management. And what is our goal? The ultimate goal is to increase the survival, intact survival, so to say. So what does intact survival means? That he shouldn't be having any BPD, he shouldn't be having any IVH, ROP. So specifically for respiratory system, we want to reduce bronchopulmonary dysplasias and increase the survival of the preterm neonates, especially so for the extreme preterm neonates less than 28 weeks gestation. So before we begin and go through the evidence and the updates, just to brief you about the quality of evidence, we always grade the quality of evidence from high to low. And in these particular guidelines, the highest quality is labeled as A, and as it goes down, the quality becomes D. And the strength of recommendation is based not only on the evidence, but also on the logistics, the preferences of the country and the context, the feasibility, training, availability. So the strength of recommendation is given based on all the taking into account all the factors, and it is given as a strong recommendation or a weak recommendation. So these are the nomenclatures which have been used both by the European guidelines as well as by our own Indian guidelines. And most of the guidelines actually follow this. So the updates are covered in 10 domains. I have tried to delineate them into 10 domains. And as neonatologists, we all know that we have to work together with the obstetricians, and the management of the newborn actually begins in the prenatal period, to say, right from the first trimester to the delivery and the birth of the baby. So coming to certain guidelines about the prenatal care, which are relevant to us as neonatologists, is the use of steroids. So the use of steroids essentially remains the same, that at least it should be given to all preterm neonates in the potentially viable period. Now, the potentially viable gestation has now gone down from 24 weeks, which we used to study 5-6 years back, to now it has gone to as low as 22 weeks. So the lower limit now, they say that it is whichever gestation for the country specific they consider as potentially viable. In Europe and in US, they take it as 22 weeks. So beginning from 22 weeks to 34 completed weeks of gestation and 4 doses of dexamethasone, ideally at least 24 hours before the birth should be recommended. And it, as we see, it is high quality evidence, A1. Regarding repeat course of steroids, it may be given if at least 2 weeks has elapsed from the last course. We all know that, and it remains the same. And it's again a high quality evidence. Magnesium sulfate should be given for imminent delivery before 32 weeks of gestation. This is for the neuroprotective effect. And again, this is again based on the high quality evidence. Continuing with the prenatal care, it should be remembered that intrauterine transport remains the ideal form of transfer, and rather than transferring the baby, no matter how many precautions we take in terms of transport incubators, sophisticated equipments, in utero transfer remains the best possible way of transferring these high-risk preterm births to a center which is well equipped to deal with extreme preterm babies. And a certain domains of gynecologist so as to say, but we should know that what are the recent recommendations for prevention of preterm birth and for management of preterm birth, and cervical encerclage as well as vaginal progesterone, which is a recent addition in the new this 2023 guidelines. Vaginal progesterone treatment should be used to increase the gestational age at delivery to reduce perinatal mortality and morbidity. Neonatologist, for us, the implication is that we should be in consultations with the obstetricians. We should be talking to them. We should be discussing with them the best practices and the recent advances for improving the neonatal outcomes. Not to interfere with the management as such, but to have a discussion how to optimize the intact survival of the fetus which is going to be born. So as I said, routine cervical length measurements as well as cervical encerclage, timely if done, they can actually prolong the gestation and hence prevent the preterm births. Unnecessary use of tocolytics should be avoided, and there are certain biomarkers, especially fetal fibronectin, which has now come up in the new guidelines. This can actually indicate you that the likelihood of preterm labor. So that would help an obstetrician to optimize the time of delivery. So what caveat or what concern they have shown in these guidelines in this update is that although steroids are a strong recommendation and there is a good quality evidence, but their misuse and abuse is also very commonly observed. And they say that maybe some women who are not actually at risk of preterm labor, they also do receive steroids. And it's a challenge to identify the right pregnant women who would be benefiting, rather the fetus who would be benefiting with the steroids. And even in Europe, as high as 40 to 50% of women who receive steroids actually deliver at term. So logistically speaking, the practical issue remains that balance the use and the abuse of this drug. So identifying the right woman who is actually at the risk of delivery within the next 7 days, identifying those remains a challenge. Coming to domain 2, now after the antenatal care, we come into the delivery room now. So delivery room, we all know delayed cord clamping is preferred, and it is actually evidence-based. And if clinical condition allows, means right now vigorous babies, we have to delay the clamping by at least 60 seconds, and it's again a high quality evidence. But when delayed cord clamping is not feasible, milking can be done. This is a slightly lower quality of evidence and only in gestation about 28 weeks. We know a recent study which has shown that there is an increased risk of intraventricular hemorrhage in gestational age below 28 weeks if milking is done. So only in gestation about 28 weeks, and only when delayed cord clamping is not feasible, the cord has separated, the placenta has separated, in those cases perhaps we can actually do milking. But the quality of evidence is again below A, that is B2. TP's devices, because of their inherent ability to control the pressures, PEEP as well as PIP, they are the preferred ones because we all know that preterm births, preterm neonates, they have to be handled gently. We have to give precise pressures, gentle ventilation, not only to prevent IVH, but also to prevent the lung injury, barotrauma. So that is why instead of the bag and mask devices, which do not have an method to actually give a PEEP or give measured PIPs, TP's devices should be used. And spontaneously breathing preterm neonates, now it is well versed with all the units that they should be stabilized using CPAP, and ventilation should be only reserved for the sick babies who are not able to spontaneously breathe. Now here is the difference between, so the right side, the orange color is actually NNF guidelines, and these yellow ones are the European ones. So European ones, they suggest that the starting CPAP should be at least 6 centimeter of water with a peak pressures of 20 to 25. The NNF guidelines still remain with the starting CPAP of 5 centimeter of water, which was there in the earlier international guidelines also. There is no rule of prophylactic surfactant. Only surfactant which can be given earliest possible is in a subgroup of neonates who are born extreme preterm, less than 28 weeks, and who are intubated at birth. In those, we can give ultra early surfactant even in the delivery room. But you should remember that the delivery room, the conditions may not be controlled. The risk of sepsis, the space, and the comfort of the neonatologist and the procedure, the feasibility of the procedure has to be looked at. So it is again based on the moderate evidence, and it's a strong recommendation of starting CPAP at 5 and no role of prophylactic surfactant as such. Continuing with the delivery room, use of target oxygen saturations, and how do we achieve those target oxygen saturation? We need to have a blenders. So the previous ones who do not have a blender, it remains a challenge, but now there are certain devices which inbuilt blenders. I think trade names we will not be taking right now, but there are certain TPs resuscitators which have an inbuilt blender which can actually titrate the FiO2. So those can be taken, and the units which are actually being constructed new, they should make sure that there is a blender inside the labor room. And initial FiO2, beginning FiO2 remains at 30% for less than 28 weeks. And they have just given a guideline that maybe for 28 to 31 weeks, we can keep between 21 to 30%, for less than 28 weeks, 30%, and for above 32 weeks, 21%. So that they have tried to give a titration. However, this again is under a lot of evaluation, and a lot of literature and trials are being undertaken as to what is the optimum FiO2 for an extreme preterm baby. And pulse oximeter is a must in the delivery room, and it's again a good quality evidence, B2. What do they say about the heart rate is, if you have achieved a heart rate of more than 100 per minute and SpO2 of 80% within the first 5 minutes, the outcomes are seen to be, again, it's a low quality evidence, but studies have shown that if the heart rate and the SpO2 have achieved their potential, I mean, above the target level within the first 5 minutes, then the outcomes are shown to be better. Intubation should be reserved only for, as I told, who are not responding to non-invasive positive pressure ventilation via the non-invasive techniques, and thermoregulation has to be kept in mind. Hyperthermia should be avoided. It's a strong evidence. NNF continues to endorse that no routine intubation now, and optimize the delivery of the CPAP using good interface, and basically switch over to non-invasive rather than intubating the preterm baby, and reserve it for only severe asphyxias. Again, it's a strong recommendation, but it's a conditional one where they see that there is an adequate expertise to manage, to deliver CPAP in the delivery room. So in India, as we all know, there is a vast disparity. Some of the units, there are highly skilled, and some of the units are still lagging behind in terms of basic facilities and basic skilled manpower. So that is why in those cases, perhaps we should see the contextual application of CPAP. Interfaces for delivery room support. The updates are many. We know certain trials like this CORSAT trial, which has actually developed a new interface, which has what is an ideal interface? The ideal interface would be the one which would deliver a good pressure. Good pressure means the ones which you want to, which have set like 5 centimeter, 6 centimeter without having excessive leakage for CPAP. At the same time, preventing the injuries and other side effects. So face masks and prongs are the ones which we have most commonly been using. And one of the concerns they have raised is face mask is too tightly applied as an interface. That itself can actually trigger sometimes apnea via trihemilocardiac reflex. So certainly there is no strong evidence which exists that simply switching an interface from mask to prong would actually increase the efficiency of CPAP, but still the search is underway. So some of the research thoughts are that maybe based on our own context and our own neonates, we should have some improved interface designs and strategies to optimize the support in the delivery room. Most of the times, even when we are working on floor, we see that agar a prong if it's not fitting properly, most of the times the CPAP is not effective. The work of breathing keeps on increasing, the need of surfactant also keeps on increasing. So it's a challenge to actually find a good fitting interface for that per preterm baby. The third most important domain would be the use of surfactant. The use of surfactant is actually the surfactant therapy, even for residents as well as what to say the ground level healthcare providers. It's both exciting as well as to see the effect of the surfactant. But again, I would say that with the use of good CPAP, optimizing the CPAP, the use of surfactant has really reduced. So let us see when to give surfactant. So most of you must be having an idea that in your units also, that worsening babies with FiO2 of more than 30% on CPAP at a pressure of 6 centimeters. So keep in mind that pressures should also be optimized at that time. We should be considering first dose of surfactant therapy. And it's again not a very high quality evidence. It's a moderate evidence. And good high evidence is that rescue surfactant should be given early. Why early? What does early mean? Early means less than 2 hours after birth. And why early? Because that time the lung still has some fluid which is there, and it actually helps the surfactant to disperse very uniformly throughout the lung tissue. So that is why they say that early surfactant physiologically, if given within first 2 hours, it improves the RDS better rather than late surfactant. And if the baby less than 30 weeks of gestation, he requires intubation anyway for stabilization, he should be given surfactant at perhaps a lower threshold than 30% also. So these are the two first guidelines which they have given. And the third guidelines is the one who is going on CPAP, the baby who is stabilized on CPAP, but FiO2 is increasing beyond 30% with a pressure of 6 centimeter water. Then you should consider surfactant. And you all must be now very well versed with the use of echoes and bedside lung ultrasounds. And if the unit has an expertise to detect RDS through lung ultrasound, then that can also actually be used. But maybe in Indian setups, we are still not that equipped. Every unit is not equipped to take on ultrasound as a diagnostic modality, and chest X-ray and ultrasound in most of the units, they are not used as an indication for surfactant. Only FiO2 requirement and perhaps the worsening distress that indicates us to give surfactant. So NNF also goes with almost the same guidelines that early ensure within the first 2 hours. Weak recommendation. Again, I think the evidence is moderate to low quality because perhaps the RCTs in the recent times are less. And RDS who are stabilized on CPAP with a pressure of 6 and FiO2 of 30% to maintain an SpO2 of equal to 91%, more than or equal to 91%. They need to be given surfactant. So what do they notice? The NNF in India, actually, they have seen that RCTs are lacking. These are observational studies. Hence, recommendation is not based on grade guidelines. Lack of skilled manpower in most of the units who can give surfactant through Ensure or LISA. Lack of availability of surfactant itself. And then if we give a blanket statement and a blanket recommendation, there may be overuse of surfactant without optimizing the CPAP first. So that is why the recommendation is weak as per the NNF, our own guidelines. So the concern remains that you must also have seen sometimes when we are managing the patient, the FiO2 is between 21 to 25%. But the work of breathing, the grunting, that continues to be there in the newborn. So the same concern the clinicians have raised in the recent updates in the European guidelines, what to do, whether to take the clinical judgment into picture, whether to see the work of breathing instead of only FiO2, and should we consider lower FiO2 thresholds for very preterm infants, 24, 25, 26 weekers? Should we increase the MAP, and should we use NIPPP first rather than CPAP before going to surfactant? So these are some of the questions that are raised. We don't have the answers. For now, the FiO2 cutoff still remains 30%, irrespective of the work of breathing. But these are certain questions which are raised, and maybe we will have answers in the coming few years. And research thoughts include the use of ultrasound, developing skills for using lung ultrasound, and having some point of care bedside tests to detect the severity of RDS. So what to do about the repeat dose of surfactant? So the European guidelines do not mention a particular FiO2 threshold for giving a second dose or third dose, but they do say that persistent high oxygen requirement, provided all other problems like malformation, sepsis, other metabolic reasons like hypoglycemia, hypothermia, all these as a cause of deterioration have been ruled out, and still the baby remains on high FiO2, then you are, as a syndromic approach, you can give the second repeat dose of surfactant. NNF tries to define it a little precisely, that a higher threshold, we can increase the MAP to 7 centimeter, CPAP to 7 centimeter, and FiO2 of 40% to consider the second dose. The first dose was at 30%. So second dose, they suggest a higher threshold use. And again, it's a weak recommendation and based on observational studies, not on RCTs. In subgroup of babies who are ventilated, and they have a history of asphyxia, maternal sepsis setting, or the baby himself has sepsis in the form of screen positivity or other clinical features of sepsis, you can consider a lower threshold of 30% in those babies for repeat surfactant. So this is the subgroup of babies. And beyond 72 hours, the surfactant use, the role becomes limited. You should think of other causes. So how to give? So we know when to give, we don't know, but we have seen when to give as per the recommendations. So how to give? So we are moving towards less and less invasive methods, and LISA is now the preferred method internationally by the Europe as well as the US guidelines. And the European guidelines also recommend, based on moderate evidence, that laryngeal mask surfactant may also be used in mature infants where the size of LMA is available. Now, what does NNF say? That NNF says again, but you see the level of recommendation, it is a slightly different. They give a weak recommendation because, again, we know that not many units and many residents, not many manpower, healthcare providers are actually trained and skillful in LISA. So rather than wasting, regurgitation problems are there with surfactant when given with LISA. So you should be actually skilled and trained to give through LISA. So if there is resource limitation and feasibility problem is there, maybe ensure can be done in those settings. So that is why this is a weak recommendation. LMA is not to be used, which is in contrast to this European guidelines. Why? Because we do not have the size we do not have the size which is available for preterm babies. We have size 1, which is available for neonates who are more than 2 kg. And again, training and feasibility for SALSA, it's called SALSA, giving surfactant through LMA. They have given a name called SALSA. So we need to have training and feasibility for this method. So these were the differences. Now, one question which was raised again is that sedation, what to do when giving surfactant, should sedation be used or not? So for that, I would say there are the clinical trials which are underway to assess the benefits. Right now, some units are using, some aren't using. We particularly in our unit are not using any sedation, pre-sedation before giving surfactant through LISA or through, obviously, for intubation also. So it's context specific and it's unit protocol based, and we are not using sedation for those. And concern with the sedation is that there may be chances of apneic episodes post procedures because of the sedation in the preterm babies, and requirement of positive pressure ventilation may be there. So that is one of the concerns. So which preparation to be used? So here, basically, Curosurf or Surfactant has a little advantage because it is highly concentrated and it has concentrated and per ml dose is more. So because of that only, maybe that has an advantage. And both of them recommend, both the guidelines recommend Surfactant based on weak recommendation based on moderate evidence, highly concentration. The dose of the surfactant should be appropriate. So Curosurf or Surfactant. So if the volume is less, concentration per ml is more, so volume to be administered is less. So LISA also becomes easier with Curosurf. That may be one of the reasons. Very interesting and exciting adjuvant therapies are coming for surfactant using steroid, aerosol as an adjunct for delivery of surfactant. So not convincingly, evidence is not very convincing for the clinicians to adapt it soon. And we do not have good, meaningful clinical improvements shown with the studies. So we are still actually searching for more evidence. And NNF actually advises that it may not be used, again, based on low evidence. So what to do for surfactant beyond 34 weeks if there is respiratory distress in preterm neonate who is above 34 weeks? So European guidelines actually have remained silent. They say that no evidence to make any recommendations. However, NNF says that in late preterm babies and in early term also, it can be used case basis who satisfy the criteria like high FiO2 requirement, other causes ruled out. What happens is in these babies, there are other causes which can cause respiratory distress. So maybe rule out other causes, and then if they are satisfying the criteria for surfactant in terms of pressures and FiO2, we can consider surfactant. And I think most of the units have their own protocols based on their own experiences. So again, it's a weak recommendation. What about the use of surfactant in other diseases apart from RDS like pneumonia, hemorrhage, meconium? They also cause RDS in newborn preterms. So in those also, European guidelines advise against giving routine surfactant in these babies. However, NNF says, again, a weak recommendation that if they are invasively ventilated with an oxygenation index higher than 15, then maybe late preterm and term with mass and pneumonias can be considered because these do cause secondary surfactant deficiencies. Biologically speaking, meconium is an inactivator of surfactant. Same goes with pneumonias where the lungs are filled with fluid, sepsis. So these are all secondary inactivators of surfactant. So there may be a role, but only in severe cases. So always remember that surfactant alone would never be the answers. So always combine the surfactant with respiratory support, good CPAP, maybe good non-invasive positive pressure ventilation, preferably synchronized one. Now, the problem is synchronized one again is 1 or 2 companies only manufacture it and not many units may be having it regularly in practice. So that remains a challenge. So go with CPAP and go with non-invasive pressures, non-synchronized ones. So always remember only keeping the surfactant in the supply won't be sufficient. Have a good equipment as a backup for ventilation, CPAP, X-rays to actually rule out the other causes and to support your RDS surfactant therapy with some other therapies for other comorbidities which may be occurring. So we talked about delivery room oxygen use. Now we go to the delivery room in oxygen supplementation inside the NICU. It essentially remains the same. The target oxygen saturation is between 90 to 94% and alarm limits 89 to 95%, which are consensus based. And protocols for screening of ROP should be in place. It's a new addition in the new guidelines, and it's again a strong recommendation. So in BPDs, what do we do? Do we keep a higher target because they are intermittently desaturating, they are having BPD spells, they may be having associated pulmonary hypertension. So what they say is approximately only 20% of the babies, they have associated pulmonary hypertension. To better stick with the existing guidelines of 90 to 95%, decide on case-to-case basis, do not allow prolonged hypoxias and apneas. So next would be respiratory support, that is non-invasive respiratory support. The debate continues between CPAP and HFNC, what to do with the CPAP, whether to start HFNC in the delivery room. So even the European guidelines gives only consensus that HFNC can be used in alternative to CPAP in some babies, maybe bigger babies, maybe who have mild RDS, because we all know that inherently because of the design, the HFNC prongs and the HFNC equipment is not designed to give precise pressures. The pressures we are setting, how much it is delivering, we are not sure. And what do we do in RDS? We have to give precise tight pressures to keep the alveoli open. So that concern always remains. So we all agree that HFNC is user-friendly. We can do KMC, we can do feeding. It causes less nasal trauma. The prongs are much more user-friendly. The healthcare providers and the patient and the newborn all remain happy. But then the actual purpose of non-invasive respiratory support is to support the alveoli and keep them open with a good pressure. So that may not be actually served with the HFNC. So CPAP continues to be popular for the treatment of RDS, and it remains the first choice. And about pressures, the range is 5 to 9 centimeter, which actually remains the same. 9 would be a little uncomfortable for many units, but this is what the recommendations say. If you have a good monitoring system, if you can see and monitor good flow rates and avoid air leaks, perhaps they go till 9, but we do not go till 9. We actually go till 7 or maximum 8 in some of the babies. Gradual weaning is advised, and sudden stoppage should be avoided. Gradual reduction results in greater likelihood of success and lesser CPAP failure. Flow driver CPAP is another device which has come up, but again, there are studies still going on. Theoretical advantage is there, but we need to yet see the clinical outcomes. So what does the NNF say? It also says the same, that CPAP is a strong recommendation to be used at or immediately at onset of distress in a preterm babies. Always have a good monitoring. Always keep an eye on the flow rate, because once the flow is increased, you may be inadvertently delivering more pressures and leading to pneumothoraxis and air leaks. Support it with methylxanthine as and when required for apneas. Bubble CPAP has shown to be slightly better because of the oscillatory effects. However, it's still a weak recommendation. Initial pressure, as I told, 5 centimeter water. Maybe for post-extubation babies, you can keep till 6 centimeters of water. And cycling has not shown to be having any benefit while weaning. So HFNC, as I already discussed, I mean, the design itself does not justify its use in RDS, where alveolar collapse is one of the major mechanism of distress. Although it is ease of use is better, so NNF actually does not recommend for primary support for RDS. Okay, as a baby grows, if he is BPD, growing baby, continuing on minimal support, maybe then that is the choice, but not for the primary support in the delivery room. Regarding the other modes, synchronized NIPPV is the best, but its availability in all the centers remains an issue. And NNF also says that the method of NIPPV may not be so relevant in Indian context, but monitoring should be there, whichever mode, whichever method the staff and the manpower is comfortable with, that you can use, be it CPAP or be it non-synchronized NIPPV. Post-extubation, in smaller babies, non-invasive positive pressure over CPAP may have some advantages. So interfaces in the delivery room, we have seen that there are certain interfaces which are coming up. Inside the NICU also, the search continues for a good interface, balance between leaks and trauma. And NNF says that CPAP with short binasal prongs and nasal mask, both are actually okay, but nasal mask may be little preferred for avoiding septal injury. So we also did one study in original study also, I mean RCT also, and one systematic review also comparing different interfaces. And we have seen that with the RAM cannula, the pressures were a little, the pressure transmission was a little less with the RAM cannula interface which was used. And so we yet need to find a clinical benefit with the use of other interfaces apart from the CPAP, well-fitting, snugly fitting interfaces. Those are definitely better. So RAM cannulas, this was another study which was a part of that systematic review. So here also we have seen that duration of CPAP was shorter in RAM cannula, but we didn't measure the pressures delivered by the RAM cannula. CPAP failure was almost similar. So on floor while working, we saw that maybe outcomes wise it was not very much different, but again these babies were a little bigger. We did not enroll less than 28 weeks gestation, where the problem with these CPAP failures is high. Lesser the gestation, more the problem with the leakage. So I will just go through the adjunctive support system, mechanical ventilation. Remember that lung protective modes are now the preferred ones in the NICU. And if non-invasive respiratory support has not worked, then only the mechanical ventilation should be resorted to. Duration should be minimized. Daily assess whether the baby requires ventilation or not. Prefer to use volume target ventilation, which most of the ventilators are not now having. and tolerate a little bit of hypercapnia, permissive hypercapnia, which we say avoid hypocapnia, because that can lead to PVL, periventricular leukomalacia, apneas, hypoxias. So the goal should be to have an acceptable blood gas, optimize the lung volume, prevent atelectasis, at the same time prevent overdistension, and prevent ventilator-associated pneumonia, sepsis. So basically what they have seen is those babies less than 28 weeks who require mechanical ventilation are actually sick, and maybe they have worse outcome because of the overall comorbidities they may be having. Maybe they are not steroid covered, maybe they have a sepsis setting, maybe they have asphyxia because of other reasons, abruptio, other maternal morbidities. So these babies are inherently sick. So those proportion of the babies who require mechanical ventilation. So do take care of that. And in case ventilated, this is one recruitment technique in Rick-Shure, which is there on high frequency ventilation. It is there in the Goldsmith also, in the recent textbooks also, where what do? You actually optimize the map at the opening pressure, so that what do? If you give an optimal map, you will actually titrate the FiO2 to a certain level that it is not harmful. You can actually optimize the FiO2 at a map where it is opening the alveoli. So that was one of the recruiting the alveoli. That was one of the strategy. And what they have seen is the type of ventilation, and the higher the ventilation, inhaled NO, they may not be very useful in the generic preterm population as such, only to be given in case-to-case basis. And whatever ventilation system the sisters, the staff, the residents are comfortable with, you should be able to master that and create expertise in that, rather than moving on to very sophisticated techniques. Early extubation should be encouraged. Daily on the rounds, assess whether the need of ventilation is there, and always look at the comorbidities, whether the baby is small for gestational age, whether there is, what is the reason of persistent oxygen requirement. And the trials, earlier we used to give trial of ET-CPAP, spontaneous breathing trial. So those are not actually very helpful. And while extubating, higher pressures of 7 to 9 on NIPPV or CPAP would be helpful. Mostly in our units, post-extubation, NIPPV is now taking over in smaller babies. We try to give non-invasive positive pressure, nasal intermittent positive pressure ventilation, rather than CPAP in smaller babies to have a successful extubation. Adjunct medications should be used as and when indicated. Caffeine is one of the most commonly used ones, and one of the indications is peri-extubational, or to facilitate weaning from ventilation. Apart from that, for prevention of BPD, many units are giving early caffeine within the first 24 hours for babies who are on respiratory support. DART regime, we all know, to prevent BPD, but it actually has a role only in ventilated newborns, that too in the first 2 weeks of life. Late steroids can actually be more harmful, postnatal steroids, rather than being helpful. Use sedatives very judiciously in preterm. The preterm newborns don't fight much, so maybe avoid using sedation. The routine use is not recommended. So this was the network meta-analysis based on which they have given this recommendation on steroids. And yeah, this one I have covered actually, peri-extubational and early. So never forget the basics of newborn care, like maintaining good temperature. Even a slight cold stress in the beginning during transport, if the temperature is not maintained, admission temperature is low, then what happens? The baby actually goes into a cycle of anaerobic metabolism, and he will be having tachypnea, he will be having distress that may be attributed to RDS per se, surfactant deficiency, which may not be a true picture at all. So always take care of the sugars, the temperatures, the overall environment of the baby, and developmentally supportive care, minimize pain, minimize handling, do not handle them roughly. So all these things can actually go a long way. You will see that in actually preventing the use of deterioration of the baby with RDS. Antibiotics like nutrition, antibiotics I would say just use very judiciously, only when it is indicated, and just look at the maternal risk factors for early onset sepsis. And the recommendation also say the same. Blanketly, not every preterm requires the antibiotics. Even a single risk factor in mother does not warrant antibiotic use. Wash the baby carefully. Only in severe risk factors like chorioamnitis, if the mother has more than 2 risk factors, then only try to think about antibiotics. Keep the antibiotics lower down in your usage or in your prescriptions. Okay. Nutrition is utmost important. What they do recommend is parental nutrition should be started from birth in all preterms, which I think most of the units may not be practicing. The babies who are 1200 grammers, 1500 grammers, they may be put on enteral feeding itself if the distress is not severe and if there is no shock, no contraindication for feeding. Start early enteral feeds and start mother's milk. Treatment of PDA, treatment of shock, maintaining good perfusion, all remain a good supportive care for RDS. And routine closure of, treatment of babies for PDA is not a good practice. If indicated, if the baby is symptomatic, all the drugs have equal efficacy. Paracetamol is a slightly less toxic drug, and maybe it can be considered when there is thrombocytopenia or a concern about renal function. So regarding hypotension, just one thing that when you invasively monitor the BPs, don't go with the numbers per se. Look at the overall picture of shock, acidosis, oliguria, capillary refill. Look at all these things and then try to treat that. Because numbers, we all know, preterm babies do have a hypotension in the first few hours in the first day, 1-2 days of life. So maybe the numbers may not be too indicative. Look at the overall baby. If the baby is active, passing urine normally, no other features of shock, maybe withhold yourself from labeling it as shock. Transfusion, regarding transfusion, be as restrictive as possible. And we do have recent trials, ETT, NO trial and TOP trial, based on which the recommendation has become higher now. There's a strong recommendation that restrictive use is required. So monitoring, invasive monitorings, do as and when required. Try to monitor clinically, closely monitor the hematological values, prevent iatrogenic anemias, prevent iatrogenic sepsis. More you investigate, more you prick, more the baby is likely to receive blood transfusions and more the risk of, again, if mislanding is there, the sepsis are more. Search for portable bedside diagnosis remains, and these are all expert opinions, the adjunct therapies. So always use it judiciously and discuss with the teams. Just a brief word about the next workshop, which actually has given some statements. So what they say is, the lesser the preterm, the lesser the gestation, below 28 weeks, you can actually give surfactant at a MAP of 6 on NIPPV or a CPAP of 6. Whereas in more than 28 weeks gestation, they say that the use of surfactant is at a MAP of 7. The rest of it actually remains the same. FiO2 need of 0.3, 30% if early, and beyond 24 hours to 72 hours, if the baby is deteriorating, then maybe 40% can be considered. Other things almost remain the same, that early surfactant is better. FiO2 is an important indicator. Chest X-ray is not mandatory for surfactant administration. There are a number of factors which predict the use of surfactant, like gestational age, FiO2 need, and the clinical deterioration. Repeat doses may be needed and given as per the indication. Gestation alone should not be a criteria. That means prophylactically, we should not give to all babies who are less than 28 weeks. So alone gestation should not be the criteria. More studies on a lung ultrasound are required, and certain barriers are timely diagnosis, lack of surfactant, etc., which we have discussed. And regarding the aliquots and single bolus, the consensus says that based on the provider's skill and expertise, you can actually give either bolus or aliquots, whatever the unit is comfortable in. Extubate as early as possible. List preferred based on the skills of the healthcare provided. And LMA only for certain cases where the size is available, the LMA size is available. It seems to be promising, but we need to have still availability and training issues. And aerosol route, again, more evidence is required. Pre-medication, sedation, discrepancies are there, and more studies are needed. Atropine is not to be used. So my take-home messages would be, start thinking from the prenatal period. Whenever a mother is admitted with a threatened preterm or a preterm labor, a preterm delivery likely in the next 2 to 3 days, do go and talk to her, explain it to her, talk to the obstetricians, optimize the other morbidities of the mother as well as the fetus. Look at the baby as a whole. Do not only focus on CPAP, do not only focus on surfactant. Look at the baby as a whole, and less invasive is more in newborn care right now. Cautious use of postnatal steroids, and ensure that your juniors, your colleagues are well trained with all the procedures. Thank you so much. I would be happy to take questions. Over to you, Dr. Snehal.
Yes, ma'am. Thank you very much, ma'am, for a very lucid presentation and very crisp and giving a nice take-home messages. Um in the chat, I have not got so much of questions, but ma'am, there's some question from my side. First is that about the antenatal steroids for prevention of RDS and neonatal morbidities. So, ma'am, the first doses we see nowadays, we have, you said, we are decreasing the threshold to 32 weeks of gestations. And then how many repeated doses? Because the Foxy is now saying no for the repeated doses of the corticosteroid, because they are also coming with an evidence that it is associated with increased risk of neurodevelopmental disabilities in this neonates. So, ma'am, what is it consensus about?
Yes, yes. So ACOG says that Foxy and Indian government does not recommend repeat course. It does not mention any use of repeat course of steroids, antenatal steroids. But whatever units and whichever units are following, those are following the American ACOG guidelines and the RCOG guidelines, which actually recommend a repeat course, only a single repeat course, not too many, a single repeat course. If she has not delivered even after that, we do not repeat after that. And in our units, at AIMS we used to give, but here case to case basis, if the prematurity is actually below 30, 31 weeker, then a repeat course is being considered in case to case basis, not as a unit policy as such. So you're right that maybe we are moving towards lesser use of repeat steroids.
Yes, ma'am.
Yeah.
Regarding the interfaces for the CPAP, we all know the pros and cons about the nasal prongs and nasal mask for the CPAP. So, there is a study I just came across a week back. There are, they have used this mask and prongs alternatively for 4 hours. So, any of this kind of an experience in your unit? And,
Yes. In our units, in 2 or 3 babies, in Snehal, where the babies are on prolonged respiratory support, very few babies. And I would say in the last 6 months, only 2 such babies we have seen who are actually severe BPD, to label it as severe BPD, and they are continuing on CPAP. They have to be continued on CPAP. The moment we switch over to maybe HFNC, they again start desaturating. So that is why CPAP has to be continued. Now, if we continue the CPAP on prongs, there is bound to be some trauma to the nasal septum. So in those cases, in those babies, we do cycle with mask versus prongs for not exactly for 4 hours, but perhaps for maybe 12 hours, 8 to 12 hours, one kind of interface, and then switching over to another kind of interface. Perhaps 1 or 2 days also we keep on mask, and then we again take on prongs and something like that. We do that, but only in cases of, say, severe BPD. Most of the babies, I would say, if they are given optimal CPAP, they do come out in the first week or so, where the risk and the trauma is less. Nasal trauma is less.
Right. I just got a question from Dr. Amit Gaur, and he's asking that at what gestational age enteral feeding can be started?
Yeah, so at Harding, you see, we are very, very proactive for enteral feeding. And even for 28 weekers, 26 weekers, we are starting with enteral feedings if there are no Doppler changes. If there is an antenatal RADF, I mean, reversal of Dopplers and absence of Dopplers in the umbilical artery, then only we are a little bit restrictive over the first 6 hours. But otherwise, in all other babies on CPAP, even after surfactant, we are going with early enteral feeding. In fact, full feeding also in 28 weekers, above 1,000 grams. 750 to 1,000 grams also, we are not keeping them nil per orally anytime. We are starting with feeds, at least minimal enteral nutrition, and then escalating gradually. So we are not keeping NPO for any of the babies. The TPN use is very less here because of that.
That's great, ma'am. Ma'am, from my side, for BPD and increased pulmonary pressure, what are your unit guidelines? Because sometimes it is very much confusing. So can you please throw a light on that?
Yes. So BPD, we try to optimize, as I said, through the respiratory support only. But if the FiO2 requirement continues to remain at 25 to 30%, we do document on echo the pulmonary pressures, and if they are high, then only we go for oral sildenafil kind of therapies, and perhaps in one or two case-to-case basis diuretic use also, but not in all the babies as a protocol that agar BPD ho gaya, so we have to give sildenafil, or we have to give some, to reduce the pressures. We don't do that. Only if it is prolonged beyond a certain period of time, the FiO2 is high. 21% FiO2 doesn't bother us. 25 to 30% if it's remaining persistently on that. We do get an echo done, and then we do document the pressures, and if they are high, then only we are treating.
But ma'am, if it is associated with PDA, then what do? You just close the PDA first, because again it would be a reversal.
Aaya nahi hai, but I have discussed in one of, few groups. Yeah, we have to manage PDA first in that case.
Yes. Yeah. Any experiences of NAVA, ma'am?
No, not yet. Are you using Snehal in your unit?
No, ma'am. No, our unit doesn't have it.
Yeah, we don't have.
Okay, so I'm not getting any other questions. So thank you so much, ma'am. Thanks a lot for nice interaction and giving me a nice answer for my questions. May I please request the clinic girl Rutumala to present certificates?
Sure, ma'am.
Yeah. Thank you so much.
So this is to certify Dr. Snehal Patil for being an excellent moderator in
Thank you.
neonatal Pathshala. And the next one is certification of appreciation to Dr. Pratima Anand for being an expert in neonatal Pathshala. And thank you everyone for sharing such valuable insights. Over to you, Snehal ma'am, to share some few words.
Thank you.
Thank you so much, ma'am. And it was nice interactive session. Thank you one and all. Thank you, Prashant bhai. Thank you, Dipen bhai. Prashant bhai, are you there? Okay. Thank you. Thank you, everyone.
Thank you. Thank you, everyone. Thank you.
So dear doctors, we are ending the session over here today. Hope to see you very soon on our platform with next and breakfast topic. So stay tuned and have a nice day. Thank you everyone.